is Aaliyah Lewis, and I'm going to be talking to you about pharmacogenetics today. I'm part of the Master of Science, Forensic Science 2020 cohort, and I am almost done, and I am on the toxicology track, but I am doing my research in pharmacogenetics. So I think it's a really good thing to learn about when you're a toxicologist. So pharmacogenetics is the study of the effects of a single gene factor on the response of individuals or population subgroups to certain drugs. The role of pharmacogenetics is something that should be taken into consideration for forensic toxicology testing, especially with therapeutic drug monitoring programs, human performance testing, and postmortem toxicology. And I'll kind of touch upon most of these later on. So I just want to review some terminology really fast. A cytochrome is an iron-containing protein that forms part of the inner mitochondrial membrane, and its function as an electron carrier in oxidative phosphorylation. Pretty much what you need to take away from that is that cytochromes are responsible for oxidation reactions, and that's pretty much it. You don't need to know that much about the mitochondria for this class anyway. A genotype is a person's genetic makeup, so what their actual genes do for them. And a phenotype is the observable expression of a genotype, so kind of how those genes are outwardly seen. For instance, someone might have brown eyes, that's a phenotype. A polymorphism is a variation in a person's genetic code that's different from what we consider wild type or normal. And it's usually just a single base pair that's different, but it could be multiple base pairs. And then a variant is just an abnormality within the genetic code. Cytochrome P450 or CYP are a family of enzymes responsible for a great amount of drug metabolism. I think it's something like 2/3 of most drugs are metabolized by a CYP gene, which is a lot. Polymorphisms in these genes can be caused by a single nucleotide change. They're very, very sensitive, very complex genes. And these variants are broken down into 4 phenotypes. So poor metabolizers, intermediate metabolizers, extensive metabolizers, and ultra-rapid metabolizers. So here's a great chart kind of showing what that means. So all the way on the right, poor metabolizers, they have 2 non-functional copies of the CYP gene that's affected. They're not able to really metabolize any drugs that, let's say if this is in the CYP2D6, they won't be able to do any, metabolize any drugs through that pathway. And then intermediate metabolizers, you can see they have some partially defective alleles, or they have a partially defective allele and a null allele. And as far as the null allele, that just doesn't work. But the partially defective alleles means that there is some type of polymorphism that makes it so that they don't have proper functioning. It's a reduced functioning. So they can take a drug that's metabolized by, again, going back to the CYP2D6 polymorphism, they can take a drug that's metabolized by that gene, but they just won't have really great metabolism of it. It'll be a lot slower than it should be. Extensive metabolizers are the normal, they're the wild type. They have 2 working copies, or at least 1 working copy of that gene. And that is kind of what most of society fits into phenotype wise. And then you have the ultra rapid metabolizers. For ultra rapid metabolizers, they have more than 2 functional copies of the gene. And again, we're going to kind of see demonstration of that later, how that affects people. But if you think about it, that gene is going to be working in overtime. So the CYP enzymes are classified by families and subfamilies. Today, we're going to mainly be looking at the CYP2 family and the D6 and the C19 subfamilies. CYP2D6 is responsible for the biotransformation of xenobiotics, specifically opioids and antipsychotics and beta blockers, and CYP2C19 is responsible for proton pump inhibitors, antidepressants, and benzodiazepines. To get into some case studies highlighting kind of the consequences of these polymorphisms, first we're going to talk about morphine. Morphine is an active metabolite of codeine. And so most people who are ultra rapid metabolizers of codeine, if that's the parent drug that they're taking, they will have an excess of morphine in their system. So this was a woman who had just given birth, and part of her recovery from giving birth was that she was prescribed codeine with acetaminophen. And this ended up proving fatal for her 13-year-old infant, who died from morphine poisoning through breast milk exposure. So your breast milk is a filtrate of the plasma, and it's been found that in people who are ultra rapid metabolizers, they can have up to 50% higher plasma concentrations of morphine compared to regular metabolizers. And that was the case with this woman. She was an ultra rapid metabolizer with an extra functional copy of the gene. So as she was taking this codeine, it was being kind of hyper metabolized into a lot of morphine, which then increased the morphine in her blood plasma and then in her breast milk. And unfortunately, because infants don't have fully formed livers like adults do, it was just too much for the baby to handle. It wasn't able to clear the medication, and it ended up proving fatal. Next, we're going to talk about tramadol. Tramadol is an inactive prodrug, and it's metabolized by CYP2D6 to form an active metabolite of O-desmethyl tramadol. In this case, a man with renal insufficiency and a CYP2D6 genotype developed postoperative respiratory depression due to a tramadol IV. So because he was an ultra rapid metabolizer, it's kind of a similar situation to what we saw last time. He was given this inactive prodrug and then just metabolized it a lot faster into the active metabolite than a normal person would. And this ended up, because tramadol is an opioid and it's acting on the central nervous system, and ended up putting this person into respiratory depression. So this kind of highlights the importance of, especially when people are in a hospital, if they know that they have these genetic changes, then they're able to treat them better and more efficiently, and can actually stop any potential harm that the drugs that are supposed to be helping them might cause. Next, we have methadone. Methadone is an opioid mu receptor antagonist. It is an effective substitute for heroin, and it's used in pain management. So multi-purpose drug. With heroin, it helps to curb cravings and not send people into withdrawal, but it doesn't really give them as much of a high as heroin does. And then it's also an effective form of pain management. In this case, in 40 post-mortem cases, it was found that people with high methadone levels were poor metabolizers, indicative of slow metabolism. So in this case, they were taking methadone and their body was slowly breaking it down, but not as fast as they should have. And then they were taking their next dose of methadone, and that was just kind of sitting in their system and building up in their system. And when I was doing the research for this, it didn't necessarily say that the 40 postmortem cases were due to overdoses or suspected overdoses, but when they did the toxicology reports post-mortem, they did find that they had much higher levels than they should have of this methadone. Next is metrazapine. I think that this is a really interesting kind of little interface for toxicology and pharmacology and pharmacogenetics and kind of all of it together. So metrazapine is a tetracyclic antidepressant exhibiting anticholinergic adverse effects. The S enantiomer of metrazapine is found to be efficiently hydroxylated by people with normal CYP2D6 genotypes. And same thing, normal CYP2D genotypes are found that the R-metrazapine enantiomer produces a more pronounced effect on heart and blood pressure. And just as a reminder, this is what enantiomers are. So you can see in the R-metrazapine that H is coming off of a wedge, and in the S-metrazapine, it's coming off of a dash. And such a small change can have such a pronounced effect on people. So ultra rapid metabolizers need higher doses of S-metrazepine to achieve appropriate antidepressant and sedative effects. But if they don't have paired ultra rapid elimination of the R enantiomer, they could have more severe adverse cardiovascular effects because they're taking and metabolizing the S enantiomer more quickly, but not the R enantiomer. So they can reach kind of a toxic or above therapeutic level of that R enantiomer if the prescriber isn't careful. Yeah, again, just really important, at least with antidepressants, they might be able to prescribe them something different that they might not run into this issue with. The last drug that we're going to talk about is clopidogrel. It is an active prodrug metabolized into an active metabolite, kind of like everything else we've been looking at. And this inhibits platelet aggregation. It's pretty much an anticoagulant. So in people who have ultra-rapid metabolizer phenotypes, they have an increased protective effect from clopidogrel after a heart attack, meaning that makes their blood nice and thin, probably thinner than most doctors want it to be, and this therefore increases their risk of bleeding. So what can be a really great thing can also be a very detrimental thing very quickly. But on the other hand, poor metabolizers have reduced effectiveness of clopidogrel and an increased risk for blood clots. So in this case, the person's taking the clopidogrel, and instead of their blood thinning as it should, it's thinning a little bit, not really what they think. So that puts them at risk for blood clots and another heart attack. I also just wanted to talk about why I think this is so important. I mentioned before that this is part of my thesis. And so I just wanted to talk to you a little bit about the research that I'm going to be doing with respect to pharmacogenetics and toxicology. So I'm going to be looking at therapeutic drug monitoring and CYP2D6 polymorphisms. Okay, so what is therapeutic drug monitoring? It is a system used to ensure that prescribed medication is being used in accordance to the prescription to try and detect non-adherence or abuse. While this is useful for determining that patients are properly taking their medications, there can also be consequences for those who are found to be non-adherent. The best types of therapeutic drug monitoring test for a steady state range compared to just whether or not their drug is positive in the sample. And steady state drug tests work on the principle that if you are taking a certain medication over a course of time at regimented intervals, then you should always have a certain amount of the drug or its metabolite in your body system at any given time. My research is based on the idea that out of some of the out of range results detected by therapeutic drug monitoring, there may be a false positive or false negative due to CYP polymorphisms that are causing the individual to fall out of range. Specifically, I'm going to be looking at CYP2D6 polymorphisms in individuals who are out of range on oral fluid steady state drug tests. I'm actually going to be working through Dr. Strip's lab for this. His lab developed an oral fluid steady state drug test that's used in a bunch of therapeutic drug monitoring programs. And we're going to be eventually taking paired oral fluid drug tests with blood tests. And we're going to be working with a lab out in Kansas City with this doctor who is very, very well known in the world of pharmacogenetics. And she's going to be helping us with our interpretations of polymorphisms to see if anybody who's falling out of range on the oral fluid drug test also has a polymorphism that could be causing that. So we're hopeful that the results of this study will validate the oral fluid drug testing, aid in an explanation of some out of range tests, and also bring into attention to the important role of pharmacogenetic testing in forensic science. So I was told to give you guys some homework assignments. So just two, but I would like for you to find a drug of your choosing and make a flow chart of its metabolism, noting if there are active metabolites Um, and then what enzymes?